Okay, so this is Spinal Cord. I referred to it obviously with about Superman. Um, so the way we're looking at it is, again, this thing. You're going to see this over and over and over. We have the central nervous system, peripheral nervous system. The afferent or sensory is broken down to somatic or visceral. Everything in purple is really what we're going to be discussing in this PowerPoint presentation. Okay? You'll also see the somatic nervous system. I'm not going to really talk about the autonomic. So when I deal with the autonomic, this will be all pink. But it's the same picture, the same organization. I just want you to see where we are in the scheme of things. Okay? You could also look at it this way, where it's all broken down, or that way. And once you're done with that, we can say, we just knocked off 5 slides. Let's go on. See how easy that was? Okay. Okay. Spinal cord. All right, so the general anatomy of the spinal cord. And we have models of this also. So this will be on your practical exam. Not this week, but when we get into the muscles, that's where we'll deal with that. So spinal cord. It's a 17-inch tube in an adult. So it's only this long. You see, what happens is it grows, but then it stops at about 4 or 5 years old. And then it doesn't grow anymore. Okay? But we still have a vertebral column that's pretty long. So the nerves coming out of the spinal cord still grow and extend lower than where the spinal cord ends. You still have nerves coming out of there. Okay? So that's what happens. It stops growing at about 4 or 5 years old, but the spinal nerves continue to grow. Okay? And it goes from the medulla oblongata, okay, which is the lowest part of your brain stem, and just as it leaves the skull, bless you, and who knows what the hole is where the skull, where the spinal cord leaves? Foramen magnum. Yeah, foramen magnum, okay? So the spinal cord begins at the foramen magnum and goes all the way down to about the level of lumbar vertebrae L1 to L2. It's around there. And that's about 17, 18 inches from the base of your skull to that area there, okay? Which is basically where your ribs kind of end. That's where it usually ends. Now, we have the central canal. And the central canal is a hollow area that's connected to the ventricles that inside the brain. And once you do the Frankenstein thing about the intro to central nervous system, you'll understand that your brain is hollow. And I've explained that people's brains are a little bit hollow than others. But our brains are hollow. And they're ventricles. And the linings of these veins have a modified epidermal cells that produce cerebral spinal fluid. The cerebral spinal fluid is going to fill the ventricles of the brain, and because it's connected to the central canal in the spinal cord, that cerebral spinal fluid will also flow down into the spinal cord itself in this central canal. Okay? There's 31 pairs of spinal nerves that come out of the spinal cord, and we have areas where there's going to be enlargements in the spinal cord. So let me show you what's going on here. We basically have our brain here, cerebellum's over here, our brain stem's over here. And what's going to happen is it's going to go down like this. But there's certain areas that are going to be enlarged. Where the cervical area is, and also down where the lumbar area is. These are going to be areas that are going to give nerve supply to your arms and your fingers and your legs and your toes. So there's going to be a lot more nerves that are going out to these areas. So you're going to have a bigger area to compensate for all those extra nerves that are going out there. Okay? When we get into it tomorrow, we'll get into what nerves we're talking about. So we call these the cervical and lumbar enlargements. Now, I'm going to define all these things to you, and then I'll show you pictures. It's easier to explain it that way, but I'll draw some pictures up here to go along with this. this point here is up here. This is where the spinal cord ends. Where it ends, it has a name, the conus medullaris. Okay? It's also called the medullary cone. Looks like a cone, I guess. Okay, tapers off. The chorda equina. We have nerves that come out of here. These are spinal nerves. Okay? And I just want to say the lumbar vertebra, this will be L2. So this spinal cord ends at L2. But we have nerves that still continue downwards. But the spinal cord, the conus medullaris, ends at about L2, L1, L2. And we have nerves that continue out here. But then you're also going to have nerves that go out like this. And it goes under the vertebrae that they come out. So these nerves, this would be L2. This nerve is L2, spinal nerve L2, because it comes underneath vertebra L2. If this is a vertebra that if I draw over here as L3, then this will be L3 nerve. Okay, and so forth. All right, nomenclature is not too bad. Okay, but look what's happening here. The spinal cord ends there, but the nerves continue downwards because they have to go out underneath those vertebrae. This kind of looks like a bushy tail, like a horse's tail. And that's what chorda equina stands for. Chorda meaning tail, like caudal, equina like equestrian, right? So that's the horse's tail. So those are nerves that are going to extend further down past where the spinal cord ends. It looks like a bushy tail. Okay? Then we have phylum terminale, or terminal phylum. Now you're going to find out when you read the Frankenstein thing about the intro to central nervous system, we have coverings around the brain. These coverings are called the meninges. If they get infected, we call it meningitis. There's three coverings there. From outer to inner, it's called dura mater, then an arachnoid, and then the pia mater, which is right against on top of the brain. The dura mater, the outer one, so just think of DAP, all right, from outer to inner. Dura mater is the closest to the skull. Well, it's not just covering the brain, it covers all the central nervous system, including the spinal cord. And the pia mater is going to also be around the spinal cord itself. So you have pia mater that's going to be around the spinal cord, like this. But it fuses at the tip over here and goes down and attaches to the coccyx bone. And what that's going to do is anchor this so it's not moving up and down. Does that make sense? Okay? We also have denticulate ligaments. And what that is also pia mater, but it's going to attach the pia mater to the vertebral column, the bones that's around it. Remember, this is going through the vertebral foramen of each vertebra. But we're going to have some of this pia mater that's going to be able to extend off the sides of the spinal cord and attach to, if I do it over here, it's not this long, but it attaches to the vertebra. And what this is going to do is anchor the spinal cord so it doesn't move backwards like that or side to side. Okay? So it's not moving all around inside this vertebral canal. Now, we have nerves, these spinal nerves, and they're going to carry sensory and motor. Things coming from, you touch something, you're going to have a nerve that goes this way, sensory, and it's going to go up to the brain. The brain's going to interpret what that is, and it's going to send motor down the spinal cord and go out there and flex your arm to get it away from there. So we have sensory and motor. So the spinal cord itself is loaded with a lot of nerves that are going up and they're going down. You agree with that? Just like Route 80 or any road. The roads that go east to west, and the cars that go west to east, or north to south. I'm great with geography. North to south, south to north. All right? So if we have neurons that go up, those are called as ascending tracts. Ascending tracts, is that sensory or motor? Sensory. Ascending tracts, are they afferent or efferent? Never mind mnemonic. Sensory, afferent, motor, efferent. If we have ascending tracts, are they afferent or efferent? Afferent. That's what sensory is. This is the other exam, the one that students find they're struggling on that one, okay? But it's not bad. Think about it. It's going up to the brain. It's got to be sensory, okay? Once the brain interprets what that is, it's then going to send descending tracts going down. Is that motor or sensory? Motor. Is that efferent or afferent? Efferent, okay? So you're going to have to use all those terms. If I say ascending, you've got to also be thinking sensory or afferent. It's all the same. It's carrying the same types of information, okay? So here they're kind of showing you, this is right. So here's where the spinal cord ends, and then you have the pia mater going down. There's the terminal phylum. Okay? Kind of like what I just drew for you. Okay? Those other things, I really put up for here, but I want you to also see, when we learn about other parts, you can go back to this picture here. Okay? All right. So, basically what's happening here is what I just drew for you. Here's where the spinal cord ends, just at level where the vertebra L2 is. All the spinal nerves will come underneath the corresponding vertebrae that they are called. In other words, if this is thoracic vertebra 8, the nerve that comes underneath it is going to be spinal nerve T8. All right? It's not too bad. All right? The only exception is the one up on top. There's 8 cervical spinal nerves. But how many cervical vertebrae do we have? 7. The reason why there's an offset there is because we have one spinal nerve coming above C1. And that offsets things. So now you have 8 cervical spinal nerves, but only 7 cervical vertebrae. But after that, the thoracic, lumbar, they're all going to be following the same pattern. Okay? This is where your cauda is. Right there. The bushy tail. The horse's tail. Okay? Now, the significance of this cauda equina. If we have to do a lumbar puncture, a spinal tap, putting a needle into this, we got to get a needle into the vertebral foramen or vertebral canal. It's filled with cerebral spinal fluid. It should be void of any type of bacteria, viruses, and whatnot. It's clear. If we suspect meningitis, we got to put a needle in there, draw some of the cerebral spinal fluid, and test it. If we have to give some kind of medication for whatever reason, an epidural medication for for many different things, but an obvious one is babies being delivered, right? To numb you from the waist down. If we have to put a needle in there and give you medication, we need to make sure that that needle is not going to go into the spinal cord. We know where there's a safe spot. It's not above L3, I'll tell you that. Because that's where the spinal cord is somewhat going to be ending. You want to be somewhat below it. So because of that, we don't put any needle above L3. Hint, hint. I would know that if I were you. Okay? Again, physiology reflects anatomy. It makes sense why you wouldn't do that. The only problem is that there isn't much of a window, because when you get much lower than L4, you got a lot of fatty tissue there and it's difficult to get to. So you only have this small area to play with. So they got to be, if you want to be a nurse anesthetist or if you want to be an anesthesiologist, you get good at this. But if you're also someone who just gave birth, or you know someone that just gave birth, you can understand that, they might have to do like 2 or 3 sticks to get it right. Not a very pleasing thing to get needles in your back for. All right? But there's not much of a window that you could actually work with here. So you may ask, well, geez, you still have nerves in there. The needle's going to go into the nerves. No, not necessarily. What will happen here, if you look at this, if let's say this is where the spinal cord ends, where my palm is, but my fingers are where the cauda equina is. If I put a needle, and if you look at the side, if I put a needle here in my palm, it's going right into the spinal cord. Not a good thing. Okay? But if I put it where the cauda equina is, what will happen is, and I'll do it this way, they move out of the way because they're so thin. You see that? So it's a safe place. It's going to be very difficult to get it where you're going to put the needle right into the nerve. I've never seen that happen. They move out of the way. Does that make sense? So that's a safe place. So if I'm asking, or I'm talking about this so much, good thing. Circle it. He may be asking a question or two on this one. Okay? All right, but questions on the lumbar puncture, don't worry about it. I put in pink and blue. That's really FYI, contraindications and stuff. I do it for other classes that would need to know that. All right? All right, so let's look at a cross-section of the spinal cord. Okay? We have a lot of different terms over here. We got tracts, horns, columns, nuclei. Woo. So let's put together a cross-section of a spinal cord. Okay. Tracts are those bundles of fibers going up and down the spinal cord. Okay? That's what we talked about. All right? It's loaded with that. That's basically what they're really made up of. But we also have this, remember how I talked about a butterfly? When you take a cross-section of the spinal cord, you're going to get this. This is dry. You're going to have spinal cord. And then you're going to get this. Okay? And there's our central canal. Okay? This is going to be anterior, and I'm going to abbreviate just to speed up time, or ventral. This will be posterior or dorsal. You understand how I'm doing this? A cross section here. You got the butterfly. Remember, the white matter surrounds the gray matter. The butterfly is the gray matter. Okay? We have tracts, and they're going to be located in the white matter. We have horns, and they will be in the gray matter. The tracts are basically the columns, which will be here in the white matter, and I'll show you what I mean by that. And we have cell bodies, which are the nuclei of the neurons. So this is what it looks like. I wanted to ask you to identify, is this cervical versus thoracic versus lumbar, but they look similar. You got that little letter H or a butterfly that's surrounded by the white, okay? So the gray matter is the butterfly itself, or the letter H, okay? Which means that there is no myelination in there. It's gray matter. The white matter is surrounding the butterfly, and these will be having myelin on them, because it's the white matter. Okay. Few things. We got the gray commissure. It's the gray matter, and whenever you hear the word commissure, which you're going to hear often, means connecting right and left halves. So the gray commissure will be found there, surrounding the central canal, which is that hole there. The gray commissure, connecting the right and left halves. The anterior white commissure is going to be found anterior to that. So the posterior white commissure will be up here too, which I don't have it labeled, but that's what that is. And the central canal is right there in the center. Okay? So far so good? The horns. We have the anterior gray horn, the posterior gray horn, the lateral gray horn. That should be pretty easy to manage also, right? Anterior gray horn, posterior gray horn, lateral gray horn. The anterior gray horn is going to deal with motor. The dorsal gray horn is going to deal with sensory. The lateral gray horn is going to deal with the autonomic nervous system. Okay? The columns, pretty easy to manage too. Anterior white columns or funiculus. You could use the word columns or funiculus. All right, or funicula. Anterior white column, posterior or dorsal white column. Posterior dorsal, same thing. Anterior ventral, same thing. And the lateral white columns. All right, so on here, dorsal columns, ventral columns, lateral columns. They're all white matter. All right? So you're probably thinking like, what's so hard about this? We'll get into that tomorrow. Okay? This is the easy part. Okay? Now, let's continue drawing some stuff here. This is a cross section of the spinal cord, but there's spinal nerves that go out. Let's draw that. Okay? It's supposed to be a flame. Okay. So this is what's happening here. You touch something, a flame. You're going to send an action potential along an afferent nerve, or a sensory nerve. And it's going to go this way. The dorsal horn is going to deal with sensory. This is going to go up to the brain, ascending tract. It may cross over, it may go straight up. That's all tomorrow, and you'll be dealing with that later. The brain is then going to interpret what that is. That's pain. So the brain kind of organizes things and says, well, we got to get you out of that situation. And then it's going to send motor fibers along an efferent tract, a descending tract. And that's going to come all the way down the spinal cord, synapse with a neuron here, and go out this way to remove that hand. Now the cell body of the green here, the sensory, are located in this area right here. This is a type that we talked about as a unipolar neuron. There's only one pole coming out of it. Sensory going this way, goes up, brain interprets, then a neuron's going to come down as motor, synapse in the anterior horn, and goes out this way to move the arm. Few things. Let's define this stuff. This is the dorsal root of the spinal nerve. Okay? It's here too. It's all this. This bump over here has a special name too. It's called the dorsal root ganglion. And it's where the cell bodies of the sensory nerves are located, at least peripherally. This here is called the ventral root. And it only contains motor. The dorsal root only contains sensory. So that's the ventral root of the spinal nerve. That's the dorsal root of the spinal nerve. So what is this? That is the spinal nerve. All spinal nerves are mixed. They have sensory and they have motor. The cell bodies of the sensory are located in the dorsal root ganglion. The cell bodies of the motor are located in the anterior horn of the spinal cord. There is no ventral root ganglion. to school, we got this wonderful model here that you actually do. It's that, so to say. Right? So to know all those parts. Okay? There's the answers to them. You can look at that, or you can look at my drawing. Okay? We also have a couple other things. This is anterior, here's dorsal. We have a posterior median sulcus that really is going to be here. I didn't draw it, but it's there. Kind of goes in like that. And then we have the anterior median fissure that kind of goes up like this. Alright, show you those. There's something wrong with this picture though, after what I've explained to you. What's wrong with this picture? Yeah, alright, it's basically there's something wrong here. That's why don't believe everything you read. This is a dorsal root ganglion, and it's showing sensory and motor through it. That's wrong. Absolutely wrong. Okay? The dorsal root ganglion is only going to have sensory in it. Okay? So I put that up there to show you, see if you could actually see what's wrong with that illustration. Okay? I don't know if that came from your book or another book, but it's out there. Okay? Alright. So, basic terminology of spinal nerves. Alright? Some of this is review. Sensory is information that comes from the body to the brain. Pain, pressure, temperature, position, the five senses, and so forth. We also have motor. After the brain interprets what that is, it's then going to send fibers downward to those muscles that contract or glands that secrete. That's motor. Efferent. Some cranial nerves, now we're not talking about cranial nerves, but I don't want you to get mixed up. Some cranial nerves may only be sensory, some cranial nerves might just be motor, but some of them might be mixed, meaning they'll have sensory or sensory and motor. But all spinal nerves are considered mixed nerves because they will all have sensory and motor components. Afferent, sensory, I erased it, and efferent nerves will be, okay? So he sees that glass of water, sends sensory from his eyes to go into the brain. It's going to synapse with interneurons in the brain. The brain's going to interpret, okay, I see what you're trying to do. Let me see what I could do if I could get these guys together in my brain to figure out what muscles I need to contract. Once it does all that, and it's easier, it's faster for your brain to do that than me to explain it. But then it's going to send motor or a descending tract to a certain group of muscles to contract and get that glass of water. Okay? All spinal nerves are mixed. There's 31 pairs. One goes to the right, one goes to the left. Each nerve have different nerve roots. As I explained to you, we have dorsal or posterior nerve roots. They carry only sensory, i.e. afferent fibers. And there's also a dorsal root ganglion there that holds the cell bodies. The ventral or anterior nerve root only carries motor, i.e. efferent fibers. Okay? That's just another picture trying to show you that. All right? This one, they're trying to show you that here is the ventral root. It looks like there's two here, but it's two branches of the ventral root. And there's a dorsal root over here. You see, what I drew over here, it looks like it's far away from the spinal cord. I did that for illustration purposes. It's very close to the spinal cord itself. This is a very short thing. Okay, it doesn't go way out of the spinal cord. Does that make sense? It's close. They're just roots. They're very small. All right, so that's the spinal cord, this beige area. And you see here's the ventral root. It's pretty short. And there's the dorsal root sneaking behind there. You can also see areas of those denticulate ligaments, the pia mater, that will come from the spinal cord and attach to the sides, so it anchors the spinal cord laterally also. Okay? So you touch something, sensory, it goes up. Keep in mind that the cell bodies are located of sensory in the dorsal root ganglion. It then goes into the spinal cord, and we'll learn all about ascending tracts tomorrow. Brain interprets, and then it goes into the anterior horn, okay? And it's going to send motor fibers from that area there, contract that muscle. Okay? Again, trying to show you the same thing on here. The dorsal root ganglion, I just want to emphasize a little bit. The dorsal root ganglion is right here. I only drew one green fiber up there, but here they're showing two. When you have a lot of cell bodies in here, it plumps up. That's why you have this little bump there, because there's a bunch of cell bodies all located in here. The cell bodies are over here, and this is actually plumping up. When you look at the anterior horn, that's the horn that's really big, because there's a lot of cell bodies in there. Okay? So when you have, and I kind of showed this before, but if this is your intervertebral disc, if it gets herniated because of a motor vehicle accident or a fall down or any kind of trauma, it could inflame itself and press against the spinal nerve. It could press on the spinal nerve or the nerve roots. If it's just one nerve root like here, the motor, then you're going to have numbness, or not numbness, but you're not going to be able to move that leg properly. If it's going to press right through this between your spinal nerve, between your ventral root and your dorsal root, then you could have issues or manifestations of sensory and motor, whether it's going to be numb or you're going to have some pain there, something like that. Okay, physiology, reflex, anatomy, right? Guillain-Barre Syndrome. Has anyone ever heard of this? Oh, okay, more than what I expected. Good. Guillain-Barre Syndrome, it usually occurs about 1 or 2 months after some sort of viral infection, whether it's you had the stomach flu or you had a runny nose and you had a cold. When we go back and we ask the people who've had this, have you had some kind of viral infection 2 months ago? Like, no. What about like a runny nose or something like that? Yeah, I think I had a cold about 2 months ago. It usually is correlated with that. Doesn't mean you're gonna get this. It just means that it's more likely it was this if you had that. Well, what this is that macrophages, again, these are part of the immune system that are going to engulf things and to try and destroy them. So macrophages start invading the myelin of the peripheral nerves, meaning here. This is peripheral, that's central, right? So they start invading in there, all right? And they start causing inflammation of the myelin. Why this happens, we're not too sure, but we have it correlated with some sort of infection. And when it starts inflaming on here, it's going to cause some partial myelination to occur. So it's almost like a multiple sclerosis thing. Well, multiple sclerosis only happens in the central nervous system, and that's a disease that's genetic that continues onward, whereas this is just self-limiting. It usually only lasts for a few months, up to a year. And what happens here is that they usually get weakness and tingling at the toes and moves upwards, and at your fingertips and moves upwards. So some people like to call this disease the glove and stocking disease, because it starts off here where they're getting very painful at the fingertips, or they can't move the fingertips as well, and then it goes this way, and then the wrist can't move, and then their arms can't move. It's like putting on a pair of gloves or putting on stockings. It flows in that way. It's very scary. You start getting numbing or pins and needles and tingling at the fingertips. You can't move it. What are you thinking? Multiple sclerosis, stroke. You're thinking of bad things. This is bad, but it's self-limiting. It's just going to go away in a few months. But that's what a doctor or the medical professional has to decide is, because it's different treatments for these. So 80% usually gets resolved within the year. Most people get resolved within 3 months. Okay? But it's self-limiting. Okay? It just usually will go away. But it's important to determine, is this something that's self-limiting or is it something that's multiple sclerosis? Okay? Because now you got to start changing the way you're going to do your life, right? The person that had this was Andy Griffith. Do you guys know who he is? Right? Okay. Yeah, Matlock. Well, anyway, he didn't die from it. It's the only person I could pick a celebrity that had this. And I find that students actually catch on to celebrities. It'd be better if celebrities they know. But but anyway, so he had this, but he didn't die from this. He had this right when he was I think in his 50s or 60s. But he died later on from pneumonia. It has nothing to do with this. But it's the only person I could think of that actually had it as a celebrity. So.
Well, a lot of people with Zika now as well.
What's that?
Zika.
Yeah.
It's linked to Zika.
Oh, the Guillain-Barre?
Yeah, a lot of adults who are getting it. Not a lot, but some of them.
Oh, because that'll be the virus that they
Right.
get. Yeah. Okay.
Yeah.
So, yeah, because they haven't really found that Zika's the new thing,
Right.
but they haven't found out particularly what virus, whether it's there's different families of viruses, whether it's a certain family or not. It just says if you had a virus before, but the Zika is a virus. Yeah. Yeah. But viruses, not bacteria. Yeah. So, okay. Questions about that? Okay. All right, last thing I just want to do really quickly is the reflex arc. Now, I'm going to go heavy into this probably tomorrow or the next day, and we'll talk about the different reflexes. But I'm just going to give you an overview of what a reflex is, and then I'll show you how it could be applied to this thing. A reflex is an involuntary muscle reaction, okay? And a reflex arc is this. If you hit the knee over here, it's going to sit, and what it's really doing is it's stretching the ligament over here, all right, or tendon. It's going to stretch the tendon, and when it does, it sends a message all the way up here, because technically, it doesn't know that you're not going to do this, but when you stretch this, you're pressing down on it. You could keep on pressing it down until it tears. But the body doesn't know that it's just going to be a little hammer. So what it does, it wants to prevent that knee or that ligament or that tendon to tear. So it sends a sensory up until it gets into the spinal cord, does not need to go into the brain. It stays in here and immediately synapses with a motor neuron, usually in the anterior horn, and sends motor over here, and it contracts that muscle. It says, whoa, you're pushing it in, I'm just going to kick it right back to make sure you don't tear it. That's the basis of reflexes. It's a protective measure, okay? We'll get into what whiplash is. That's very similar to this, okay? So that's what happens here. So a reflex, we have a spinal reflex, it synapses in the spinal cord, it does not need to go up to the brain, which means that this happens even quicker. If it goes up to the brain's got to think about it, that's too late. So it needs to be able to do this without the brain's okay. And the knee reflex is a good example of this. You can also do a cranial reflex, and this would go to the brain, only because there's no spinal cord here. So if I touch your cornea, you will do the blink reflex. But it goes to the brain and goes right back. It doesn't go to the brain to think about it. It just goes there and it synapses immediately and causes you to blink. Okay? So that's the difference between spinal reflex and cranial. We'll get into the spinal reflex later on. It's later on in this PowerPoint. Okay? And you can imagine doing this on amphibians, that this could be very hazardous. All right, it's supposed to be a joke. Okay. So, let's play Frankenstein. Okay? Let's play Frankenstein. Now, they used to do this back in the 40s and 50s, so we've learned from this. But this actually will help you to understand what's going on here. This is our setup. Very similar to that. Okay? What happens here is you have a frog, and we're going to touch the right foot of the frog. That's going to send sensory here. Now, this is a reflex. It's going to send sensory here. Does not need to go up to the brain. It sends sensory over here, and it synapses with a motor neuron on the same side, and it's going to kick that leg back. Next time you get a frog, do that. Not this. Do that little experiment. He will kick back. It's a reflex. Now, here's where we're going to, does that make sense before I go on to the further thing, right? Just what I just talked about goes this way, synapses here, you touch here, it just kicks back and goes right back. Okay? Now, let's do a little Frankenstein thing. Okay? We're going to cut the dorsal root ganglion here. I'm sorry, the dorsal root here, leaving the dorsal root ganglion on this side. And we're going to cut over here, leaving the dorsal root ganglion on this side. We're going to fuse this part of the dorsal root and that part of the dorsal root, I'm sorry, this part of the dorsal root, to create this. You see it? See where A is and B? Now you fuse it together. See it? What's going to happen here is this. You touch the right foot, sensory's going this way. It goes into the dorsal root of the other side. And now it's going to go and connect to, or synapse, with the motor neuron on the left side. So when you touch here, the left leg kicks back. Does that make sense? All right, this is to make you understand that system and a reflex, that it doesn't need to go up to the brain. Okay? Does that make sense to you? Get your dissecting kits out. We're going to start now. Okay? But we can learn from these. I mean, this is now the animal activists will be all over this. But it shouldn't be that we should throw out everything that was done in the 1940s and 50s, because you get to learn about that. Okay?